appreciate the invitation to be here. A couple of my transformation team colleagues are also on the line, in addition to the Unite Us group. So yeah, we're very excited about this pilot program that we've been working on for more than 2 years, I would say. My background is I'm a health economist. I actually am a research associate professor at Washington University, but I do a lot of my research in rural health policy and have been funded through the Federal Office of Rural Health Policy out of the University of Iowa for about a dozen years. So a lot of the development of this model was informed by different things that I kind of picked up over time, thinking about what rural health looks like in America, and what are the gaps, and kind of what are the strategies that might work. So yeah, we're super excited that this is actually getting off the ground, and I also see that there's at least a couple in the room that are from some of our ToRCH sites. So I appreciate you guys joining. That's very cool and fun that you're here. And so I guess with that being said, should I go ahead and start my presentation? See if I can make it happen here. Slideshow. Looks good. Okay. There we go. Does it look right? Yes, great. Okay. Yeah, thank you again for having us today. And I'm going to go ahead and kind of walk us through what ToRCH is. In March of this year, after working for several months with CMS, we got them to approve an amendment to our 1915B waiver that authorizes a new program under what they call their primary care case management authority. But we have kind of added this twist that it's focusing on community strategies that address the health-related social needs, the challenges that often derail primary care, and thus set up downstream consequences that create or continue poor health. So this is the product, like I said, of more than 2 years of development, and it's a population health model that has the aim of improving health and controlling costs for Medicaid participants in rural Missouri. The model is going live across 6 sites in the month of July. And when I say live, it's going fully live. All aspects will be live in July, or I believe early August for a couple of the sites. And so that's really getting to the very exciting part of all of this development. The purpose of the model is to direct new resources to rural communities that commit to addressing these upstream causes of poor health to deliver demonstrated value and improved health at the population level. The communities are explicitly including primary care partners and CBO, community-based organization partners. So it's not just the hospital, although it does include the hospital as a leader. We're integrating social care supports into clinical care. So, thinking of these two things very much intertwined and affecting each other, so that clinical outcomes will be less likely to be compromised by social challenges. We want to better leverage existing social care funding and pay for value. There is a lot of funding out there for various aspects of social care and challenges, but it's often very fragmented, and that's part of the goal of ToRCH, and using a platform like Unite Us is to think about that more comprehensively, and refer people to options that currently exist. We want to create a new role and a new path to sustainability for rural hospitals, and especially the smaller rural hospitals. That second part might be the biggest factor to have a new path to sustainability as a leader of a community population health strategy in your community, and to be able to get paid for that. So the first cohort of hospitals and communities are listed here. So we have Ray County, Golden Valley Memorial, Bothwell, Citizens Memorial, Phelps Health, and Salem Memorial Hospital as our first cohort awardees. The total Medicaid enrollment there is relatively small. The total Medicaid program is anywhere from 1.3 to 1.4 million people. So this is relatively small. And of course, it's focused on rural, where the numbers are always a little bit smaller. You can see the map of where the different counties are if you're not familiar with all of those. Um, I think one of the really key parts of this model that I felt really strongly about from the beginning was that it would have a local structure, that it would look in each community to say, like, what's going on here? Who are the players? Who's already involved in health and population health, community health, and can they partner together in new ways? So the key players we think of as the hospital, the primary care, the behavioral health clinics, the local public health agency, and then also those community-based organizations that provide those social services day in and day out. So we asked the ToRCH Hub to create a leadership board that is comprised of members of these three groups, and they come together and they make decisions based upon the specific needs and assets of their community. And when I say community for this purpose, I mean a county. For cohort one, for the beginning, each hospital is only taking on their home county. Ultimately, we hope to be able to extend that out to include adjacent counties that don't have their own hospital. So maybe like one county could sort of adapt the county next door. But for the time being, it's one county. Um, so we have a number of different goals. This is a value-based model. We're trying to get to sustainability by having a kind of a shared savings approach. So the main goal, and this is the basis for the shared savings we hope to achieve by a 5-year kind of maturity target, is to reduce all cause hospital utilization for all Medicaid recipients within the geographic community being served, regardless of the location of the hospitalization. And there's some stuff in bold there that I just want to emphasize and draw a line under, and maybe I should have animation here, because it's really different from what people normally think of. And I think the hospital's first thought is like, "What? You want me to you want me to lower hospital utilization? Like, that's how can that be sustainable? Like, I'm a hospital." Um, but in rural communities, we find, and we look at the data, and I'll show you a slide about this later. But we see that the vast majority um, of the spend, the expensive hospital utilization that's happening in rural communities is actually happening at other facilities. So the more complex, more expensive things are actually happening typically in St. Louis, in Kansas City, in Springfield. And so the idea is that's being used as a kind of overall global measure of the health of the community. And in fact, just saving a few NICU babies, for example, super expensive thing for Medicaid to pay for, if we can come up with a strategy that prevents those from ever happening, and then calculate some savings based upon what Medicaid would have spent for that, then that's a win-win. That's kind of what the goal is here overall. Um, we have some other incentivized. I think of them as quality goals. I mean, they're still about reducing some hospitalization metrics, but these are avoidable hospitalizations and avoidable ED use. And so these are pretty narrow definitions that are more about, kind of having a better strategy to avoid having people in the hospital when they really should have been in primary care first. And these are also net budget neutral for the cohort. So it's a quality goal, but it's not something that's going to break the bank one way or the other. We've been working really closely with the Heidi team. So that's the Hospital Industry Data Institute, I believe, and they're an arm of the Missouri Hospital Association. They've been developing this really cool dashboard that's going to allow sites to monitor all these goals and then even drill down and do analysis of like what are the contributing factors. If we're seeing a bunch of NICU babies and they're going to St. Louis, like who are they? Why are they happening? Like what's the cohort? What's the demographics? And even like which part of town do they live in? There's some mapping there. Like there's just a bunch of potential for being really able to analyze the data and develop strategies to address and target to achieve the goals. The community, getting back to that local idea I mentioned earlier, each community's leadership board also gets to identify 5 local priorities for population health improvement. We ask those be measured uniformly. They have to be able to be measured for the county. And these are also incentivized. These contribute to an increased shared savings percentage if these get achieved. So there's some examples there, but these are really things that are more, they're a little more process measure-ish, and they are a little bit more about prevention, access to preventive services. So you can see like some of these are ones that our sites have chosen, but we allow them to customize and choose what they think is important for their community. So a little bit more about that idea that I mentioned at the beginning, like this is a community-based primary care case management model. It's about developing strategies that harness the knowledge of the leadership board. Like, what do we have in our community? Which partners do we have? What do we need? What stuff needs to be developed in order to make this work? Kind of combining that knowledge of the community with your clinical expertise, like which are the things that really drive bad health outcomes. And so, the usual suspects are listed there in terms of the health related social needs that most of us probably are very familiar with. But kind of mixing and matching and figuring out like, what does it specifically mean to offer food and nutrition education? What would that look like in my community? Which partners do I have available? Where are the people who need that? So just making it their own unique version. And I want to say, I want to this is a really important point here too. If you're listening to this from a rural lens, you might be like, well, that all sounds great, but what if there isn't that capacity? And I think that one of the really unique things about this ToRCH model is that we've attempted to answer that question. We've integrated capacity building dollars, and these are actually state only dollars because CMS doesn't allow investment types of activities, which parenthetically, I think that's kind of crazy, but you can't invest in something up front, but you can pay for it downstream after it's really expensive. So we are braiding some dollars here in order to allow the different leadership boards to grant some base funding to their community-based partners to address gaps in available CBO services. So because you might have capacity issues, you might lack resources, there's a smaller scale of operations, you might have trouble, staffing a building for, a normal amount of hours in a week. There could be a number of different logistical challenges. There might be, situations where it'd be great if we had this resource, but we don't even have it at all. We'd like to set something up. And this thing is really the most important opportunity for the ToRCH community to get creative in addressing the specific needs of their low income population because there are very few, I mean, I shouldn't say it like that. There are fewer strings attached. Obviously, we still have some guidelines about how we want to see this money spent, but it is more about building capacity, coming up with the strategy of how we think we're going to meet the goals. And these are the things we want to invest in to make that happen. Um, so in terms of how this is operationalized, we obviously have to rely a lot on the providers, the clinical providers who are going to be the kind of the first point of contact for most of those Medicaid participants. Because remember, this is a model about how social determinants of health are interfering with the ability to maintain or improve your health. So it's kind of from that clinical lens. We expect to see the primary care entities in the community, with whether it's an F2HC, a rural health clinic, a school-based clinic, the local LPHA, whoever it is in that community, they are probably the front line for conducting most of the social determinants of health screenings. They're going to be key participants in the referral platform. There's room in the model budget to reimburse for that. So we are not asking primary care to do more for no reimbursement. There are dollars in place for that. And really the goal is to have them, becoming um, more familiar with and more proactive, I guess, about asking whether there are needs and offering to meet needs, and doing it in the context of that kind of health based conversation. And so we think that this model provides that opportunity. So I know Mike has a section of the presentation in a little bit here, so I won't say as much about this as I otherwise would in this deck, but basically, the the IT basis for this entire model is a CIE, a Community Information Exchange, a referral platform. Unite Us is the selected vendor for at least for the first cohort. Um, and we really think of them as a linchpin for making all of this stuff happen in a way that's efficient and also providing a lot of good data. So not only can the referral be sent from the medical provider to the CBO for resolution, but we also will see how that resolution happens. The loop gets closed. Did the services get received? If they did not, then why not? The platform has the ability to aggregate that referral activity up to the community level. So you have a dashboard that's showing you your entire county. You can also pre-screen for eligibility for other existing programs. That stuff is being built into the Unite Us platform so that case manager or that community health worker who's doing screenings is able to kind of go through a list and say, oh, look, like here's an option that I can send you to for which you're probably eligible, rather than having to have that kind of all in your mind as a mental Rolodex, which we understand is relatively common. Um, Assess the performance of of individual CBO grantees. So, like I said earlier, um, there's going to be grantees in the community who are partnering in the hub model who have received funds to start up something new or expand capacity. So we'll be able to use the platform to actually kind of keep track of them and how well are they doing, because that's kind of the feedback loop there. And even conduct gap analysis, meaning like we can see who we are seeing come through the door, but who are we missing? So comparing what we do see with the underlying, like whether it's coming from census data or some other data source, like who are we missing? If we subtract off who all we know is there, and we, can see the ones that do come in the door, then we're left with a better picture of who needs more outreach. And since this is a population health model, that is a really important component. So these are some slides. Again, I think I'm just going to click through these quickly because I think Mike will say more, but this is just some dashboard views of stuff you would see in terms of like how the outcomes get recorded and whether they're resolved or unresolved. Like, and these are all hypothetical data. This is a demo environment, so not real data, but you can just quickly like scan and see, here's what's going on, here's how the trend is over time, etc. I like this one too because this is an overview that you can check just your county. So there's a lot of counties checked here, but for our model, the hub would be interested purely in the one county. So they would be able to kind of filter that out and look at like who are we hitting, who are we missing, what's the volume, and then like here's the view where you get to see, okay, who all is sending. So this is going to be the hospital's ED, maybe the hospital, the inpatient upon discharge, that unit. But it's mostly going to be the primary care and related entities in the community. And then the receiving organizations are all your food banks and your area agency on aging, and the different groups that are already out there providing services, and the ones that have partnered with the ToRCH model and are receiving some capacity building funds. You're going to be able to the ToRCH hub can track the amount of activity that each of those is providing, and then even drill down on kind of making sure that they're performing the way you're expecting them to. This is that gap analysis. Obviously, the demo environment looks like it's North Carolina, so that doesn't help us too much. But just to be able to see, there's a lot of stuff to look at, I think, is the takeaway on this slide. So I don't want to belabor the point here, but you can kind of see that one of the big themes here is that we have a lot of data, or we are generating a lot of data. So we're going to have, we're going to understand the met needs, also the unmet social needs, and be able to combine that with the clinical data, which is what we will be doing within MoHealthNet. So as these data come in from Unite Us, we can merge them with, records, claim level records of the Medicaid participants in the county and say like, oh, does it actually matter if we meet those health needs? Do they have a better trajectory? Do they look like they're more healthy? Are they avoiding some of the kinds of utilization that we know represent really bad health? If we have a diabetics, we can kind of tell how they're progressing through their disease. So if we can provide them more healthy meals, foods, um, nutrition education, all that kind of stuff, does it even help? Does that work? So that's kind of the heart of the model is really to learn specifically like what works. We think this works, but there's still kind of a recipe to figure out exactly how it works. We think that the rural communities that we've chosen and other potentially other rural communities in future cohorts would be ideal settings for this approach because the community can be defined. You can kind of draw a circle around a community, or you can use the county, and you can be pretty sure that you are able to have a good sense that you are affecting the population health, and it's not your neighbor that's their strategy is actually doing the work. So we are also, we're doing some data sharing and providing some claims analysis back to the communities. We also have this Heidi dashboard that I mentioned. We also have meetings across the ToRCH communities, and we have a message board so that everybody can kind of communicate with each other, work together, share insights, knowledge of things that worked, things that didn't work. So that's a pretty cool thing about the effort, I think, as well. Um, this is just a quick example, just to bring to life what it means to say strategies in the first place. So, like, let's say that we're noticing a lot of food insecurity in the community, and we think that this is detrimental to health. We want to focus on high quality nutrition, and we're thinking that there's a couple different things we're targeting. We want to improve obesity and diabetes control. We're also looking to improve pregnancy outcomes. So maybe with that in mind, the leadership board provides capacity building funds to two food banks. And one of them, it gets the money to start a community garden, and they really focus on fresh fruits and vegetables. And then primary care is like, okay, that's the place we're going to send some of our patients who really need a supply of produce and whole grains, and we're going to, also provide some education and make sure they know what to do with that food. Maybe Food Bank B does home delivery of meals and free weekly cooking classes. Maybe they're providing some childcare to bring more young families or mothers in. And primary care is referring some other patients to that scenario. And, so you can see the idea is like try different strategies, try to meet people where they are, try to get people to have better nutrition in their lives. And so you look at the data over time and you say, well, which strategy seems to be working? Maybe one works for one and a different one works for a different population, and that's fine. This is a model about learning what works for whom, not necessarily that there's one thing that works for everybody. So maybe one strategy really is superior, but a lot of times it's probably going to be some things work for some and other things work for others. And I think that's one thing that we really want to understand more. I talked about this before too, but the opportunity for coordination I think is huge here because we are building all of this information into Unite Us that allows the screener, the person who's working with that Medicaid participant, to really think about multiple needs at the same time. Because I think a lot of times someone's presenting with that most urgent need, and there's, the idea is, well, we want to address that need because it's right there. Um, but being able to do a comprehensive screening, maybe using the Prepare tool or a different similar tool, allows kind of the comprehensive set of needs to be understood and considered in tandem. We're going to have program eligibility for all different programs as a pre-screen feature in the platform, so that again the ToRCH Hub can better leverage other existing funding streams before tapping into ToRCH dollars. This is just I thought it was kind of a nice visual of how uncoordinated things can seem, especially when someone's in poverty. There's lots of different contributing factors. We want to try to make this a little bit more streamlined rather than having a lot of silos. Um, so just to say a couple more things about the services and supports that are included in the platform. In other words, that things that are going to show up if someone is screening an individual. Programs that are across state agencies that address the SDOH concerns of low-income Missourians. Um, Programs and supports that are available to dually enrolled beneficiaries, by which I mean, both Medicare and Medicaid. Um, Programs and supports that are available to those who have a managed care plan. Our Medicaid MCOs actually offer quite a number of benefits, but they aren't very well known. A lot of people are eligible for stuff that they don't know about. And so we're also building that into the platform so that hopefully we can really boost the uptake of some of those opportunities that people have and just don't know they have. Um, Programs and supports that are available through local organizations with grant funding from whatever source. Just if somebody's out there that wants to help a certain set of individuals, we can put that into the platform. And then the last thing is these supplemental B3 services. So I'll say a little bit more about what that means in just a minute. This I'm not going to read this off, but the point of having this is to say there are a lot of different social determinants of health activities, programs, policies across state government. So, like one of our goals is to make sure that people, if you qualify, if could use vocational rehabilitation, maybe you don't know that that's a thing that could be available to you. And if we build it into the platform and it pops up, then maybe that's helpful. And so there's a number of different things like that here. The second page here. Um, Again, not the purpose isn't to read that off, but just to say that like we're trying to have this platform be very comprehensive in terms of popping up programs and assistance of whatever sort that a low income person who's on Medicaid would be likely to be interested in. Okay, so now I want to talk for a couple minutes about B3 services. And I know I'm about almost to the half mark, so I'm going to try to wrap up soon and leave Mike some time. Um, but I want to explain what B3 services are. They're named after the section of the Social Security Act that they get described under. So, not a very glamorous name, but the waiver that we have is 1915B. And there's a section B3 that basically says that Medicaid programs can offer sort of additional, like health adjacent benefits and services if they do so in a cost effective manner. So basically, the same premise that ToRCH has, which is that if we do this stuff, we're actually going to lower the overall spending because we're going to keep people healthier. So these are the approved services at the moment. These are the ones CMS has approved for us. We can always go back and amend our waiver and ask for additional things to be added to this list. But we decided to start with kind of the core things and maybe add from there if we see fit. And we've been asking our hubs, like, think about what's missing here. If you had a wish list, what would be another thing you would put on here? So one thing is transportation assistance to health related appointments or to access any of the other services on this list or services offered by other state agencies such as job programs. So basically, this is transportation that's supplemental beyond that covered benefit. So it's, Medicaid does cover what they call non-emergency medical transportation, and that is taking someone to their actual doctor appointment or to their medical visit. So that's not this. This is transportation to some other type of health related appointment. It might be like someone wants to go to an AA meeting, and that's something that would be appropriate for their health. This would allow transportation to happen for that kind of thing. Tobacco cessation meetings, yeah, anything like that. Transportation benefits that are already covered by managed care would not. We are under strict orders to not be duplicative. CMS doesn't want us paying twice for things. So then the second one is food and nutrition education, such as better ways to use SNAP and WIC benefits to promote health, cooking classes to improve chronic condition management through diet, that kind of category of things. And then we also have specialized food and nutrition targeted to people with certain health needs. And this is more about like actually having medically tailored meals, if you will, whether they're home delivered or they're picked up by patients if they're not homebound. Um, so this is more the food itself. This is more the education, and then we also have the opportunity to provide home remediation goods and services, either for mitigating health risks that are related to like air quality and breathability, that sort of category, or also for safety. So if there's something in the house that's unsafe, whether it's a fall hazard or potentially, a bed bug infestation or something like that, those could all be home remediation. So those are when I talk about B3 services, these are what they are. Um, I am gonna. I know that people are probably really curious about the dollars, so I do want to cover this. I'll try to do it quickly. So there's a number of different funding sources that are all being braided together to kind of comprise the totality of what dollars are available for the community. So this is a medium county. We do have small, medium, and large rural county designations. A medium county would receive in year one a $225,000 base allocation to fund approximately 3 positions indefinitely, indexed for inflation. And this is to run the model, to do the data analysis, the strategy, the convening of community partners, all that stuff. Um, and then there's an operating fund that's more about like doing the screenings and providing the services. So these are dollars that are scaled to the population. So Medicaid enrollment, if it's $5,000, then you would multiply some stuff by 5,000. You also would get capacity building grants for your community-based organizations that would be, can't remember the formula for this, but basically you get a chunk of money in the first couple of years, and then it does start to diminish. By the time you get to year five, those funds do go away. They are meant to be upfront investment funds only. Then you have funding for screenings and referrals that get prorated among the clinical partners according to how they're, who's contributing more to the screenings and referrals. And then a budgeted amount for B3 services. Again, this is a there's a formula under there. Um, Annually $1 million that has to be spent. Unspent funds don't roll over. But basically, they can lean in as hard as they can and stay within this budget to provide those services that were listed on the previous slide. Um, when the hub achieves its population health goals, they get additional dollars. As we get to year five, we think of year five and beyond as the mature model. And in year five and beyond, the operating fund that the ToRCH Hub gets is at least the floor is 60% of MoHealthNet Division's savings on all hospital utilization. And we calculate that relative to the non-ToRCH rural counties. And it's adjusted for like the different types of enrollment. Um, so it's a pretty good way to compare whether ToRCH is making a difference in comparison to other rural places. So we throw out all the urban data. And then there's a 2 to 3% bonus for meeting or exceeding each of the 5 population health goals. So really our ultimate goal is that everybody gets 75% back. And honestly, the other 25% is kind of what covers the rest of the model, including paying for Unite Us and things like that. So really, this model is aspiring to be revenue neutral to the state over time. So that's kind of how we think of it, and that's just a general example. Um, this is a combined total dollar amount for all ToRCH counties. So these are our 6 counties currently. So in fiscal 2023, the estimated spending on hospital services for residents of ToRCH counties at ToRCH hospitals was about $100 million. The estimated spending for those same people at other hospitals was to, I don't know if I subtracted that off. I think this is at any hospital is $223 million. So basically, over the whole cohort, about 55% of spending occurs outside the walls of these ToRCH hospitals, and that's where the real opportunity lies. You want to identify population health and social determinants activities that can reduce this relative to non-ToRCH counties. And so the shared savings is based on reducing total hospital utilization for the ToRCH county's Medicaid participants. So it's the total not so much what happens here. And we've actually had a number of discussions with our ToRCH sites, our first cohort. And some of the opportunity here that the Heidi dashboard brings is that there's a new opportunity for what I might call market research. They'll be able to see a little bit more about what's going on that they currently don't even see. Like who in my county is driving past me to access services that I provide, and trying to make sure that we figure out a strategy to kind of keep those people closer, keep them more attached to their local community and local, health infrastructure. So in fact, you could actually end up with a strategy where you don't decrease this at all. You maybe even increase it, but you still lower this, which the incentive is based on lowering this. And if you can get a greater share to kind of fall in your bucket as a ToRCH facility, then more power to you. The funding authority over time, just if people like a colorful picture, the idea of this is that ultimately these blue dollars are, um, in the early years of the model, they are like this budgeted amount that we provide, and we have specific ties to how it gets used, and it's authorized by B3 authority. But over time, as we transition to the mature model, this gets kind of replaced by a shared savings calculation. So, you know, the basic mechanics of the model, like these dollars get funded throughout. Like this doesn't change, right? Um, the blue capacity building dollars, as I mentioned, they do go away. Those are investment dollars and they do dry up. But the idea is that we're converting, we're investing kind of upfront in getting this process going, but ultimately we want to convert to the point where we are fully funding this model off of the savings that it generates. And that my little green arrow here is meant to say, like, actually, this green bar, hopefully will go farther up than that. Like, hopefully, the savings generated will more than cover the B3 services that need to be provided. And I think that's where the sustainability opportunity really comes in. And it says something here a little bit about this. Maybe no, it's the next slide. I do want to kind of make the remark that avoidable ED use and avoidable hospitalizations, those are calculated for each hospital. These dollars go into pools and they get divided back out across the cohort. These are pretty minor elements of the model. The avoidability definition is pretty narrow. The dollars stay in the cohort. So I don't want people to focus too hard on this. As improvements are made, these pools shrink. The measures would be anticipated to be dropped in the mature model because there's only so much you can do on those measures, honestly. Um, but here, this is the one I wanted to end with, and then I'll turn it over to Mike. And gosh, I'm giving him at least 15 minutes. Recognizing that MHD goals on reducing hospital utilization represent revenue losses to the participating hospital, this model allows the funds to be earned back as shared savings, and rural communities can share savings due to lower hospitalization rates that are occurring elsewhere. Again, the savings will be estimated in comparison to non-ToRCH rural communities, which control, the estimation process will control for demographics so that we're making sure we're doing a fair comparison. Participating hospitals earn shared savings on all avoided utilization, giving them an opportunity to be financially viable as an anchor institution in the rural health community for generations to come. And I think that we hope, that's the aspiration, that this model offers rural hospitals the potential of a net gain in revenue while redirecting resources to rural communities. And I really want to emphasize this thought here because I think in a lot of in a lot of markets, the dollars tend to flow from rural to urban. And I think that healthcare is no exception. And this is an opportunity to take some of that and push it back the other direction. And that was a big goal in designing it. So I think that's all I got. I see a whole bunch of things in the chat, but I'm going to turn it over to Mike and see if I can answer them in the chat while Mike takes over.
Awesome. Thank you, Dr. Barker.
Oh, I see Justin's been answering them in the chat.
I was just going to tell you, I think Justin and I were trying to tag team a few of those
Justin's
and make
covering it.
sure.
That's
Yeah.
great. Thank you, Justin.
Um, For those that don't know me, just a quick introduction. I see a lot of friendly names out there in the attendee list. Mike Mitchell, I'm one of our senior strategic directors here at Unite Us. I did not coordinate my shirt very well today. I live in Missouri, even though I'm wearing an Arizona State University shirt. So my apologies for any confusion that may offer. But I'm excited to share with you all a little bit about the Unite Us role, which is a small role in the overall ToRCH model, but one that contributes hopefully outsized versus what our initial role is to the success of the overall program. So I'm going to screen, do a few slides. I also wanted to call out that for those that are unaware, Missouri Department of Social Services has put together a really great frequently asked questions website, and I'll post this in the chat so folks can look at it and get some questions answered around the ToRCH model. And they also have some other really good informational sites available for folks that just want to take a second, or if you come out of this call and you say, hey, I need to share this with my leadership at this, my organization, this would be a great way to potentially do it. So uh, I'll talk briefly, and I'm going to breeze through some of this. But Dr. Barker mentioned, that she had that slide up there with the very lots of lines going all over the place, connecting different points in terms of how individuals navigate social services and healthcare and their government involvement, et cetera. I have a little bit simpler slide that shows this too, but the idea is that there is a breakdown currently in a lot of ways between how community organizations, government entities, and healthcare providers really provide services for a shared individual and a shared patient or client. And what we at Unite Us hope to move towards is how can we break down those sectors across all of those different domains and make sure that we're rallying around the client so that they're not having to figure out where to be, when, who owns what next step. And really, what we're doing is we're enabling the community to coordinate services in real time with each other more effectively for the patient or client being served. And uniquely about the ToRCH model is that some of those services based on their individual communities will actually be reimbursed for those services as they provide them. And so how do we do that? Right? It sounds great in theory. How do you break down these silos and actually start coordinating? Well, technology plays a role in that, right? But I want to be clear, technology doesn't matter without the people behind it and in front of it using it. So I'm really excited with the 6 ToRCH sites that are going live. They're committed to this. They are driven to make this a success, and technology is helping to enable them to make that success happen. And so it's all about how do we help communities do this care coordination in a seamless way, so that we can use the tools to identify the needs that an individual or a community has. Then we use the technology to connect and deliver those services, connect them to organizations. And then in the ToRCH model and models around the country, they are starting to use technology to help generate payment for those services. And at Unite Us, we see this as the future and currently as the present of how healthcare will be delivered. It's a really exciting moment. Share a little bit of story about some other places that have gotten slightly ahead of Missouri, but we're catching up. So it's really exciting. But one of the things that is required from technology are things like being able to really have visibility in real time to where journeys are for individuals and clients, and having that shared client record so you can see the full longitudinal picture of how other organizations are working with and serving that client, including some really cool features that for those of you who maybe have met with us over the years, you may not even know that we've enhanced, but things like the ability to do real time and HIPAA compliant messaging and chats with other organizations. So if you have a question, you don't have to find a phone number, call, or do an email or a fax. You can do it right through a technology and do it in real time. You can share things like case notes, right? So you can see who's doing what. And then ultimately making it easy for users to do things like automated screening workflows, automated referral tracking, and automated billing and invoicing. And I saw there was a question from someone in the chat earlier about, well, how do we know? Are we then required after we send a referral to go do the follow up and find out what happened? And the answer is no. And that's one of the things that the technology is bringing to the table is to get those real-time updates and to see that real-time status of what happened. And then as organizations close the loop and provide a detailed and measurable outcome that people can see that outcome, meaning what service was provided and how, or why wasn't a service provided. And then we use that information to reinforce the programming and to reinforce how the network operates. And Mo HealthNet has the visibility to see what's working, what's not, where do future funds need to be resourced towards, and where do future funds need to be brought back from because we are overutilized or excuse me, capacity wise. And so there's a couple components that make this possible. And that includes the ability for individuals to sort of see and understand all the resources in their communities, and also for them to start their journey themselves. We also have the ability to do that closed loop and invoicing. And I want to be really clear on one thing. It is Unita's vision that these community-based organizations and social service providers should not be medicalized in providing these services. And so it's really important from our side that they have tools to do this that don't require them to understand things like 837 transactions or HCPCS codes, right? So understanding how that'll work for them so that they don't have to do that themselves. And then ultimately a real-time data environment so you can see what Dr. Barker was showing earlier. Where are referrals starting? How are they working? How many touch points is it taking for someone to get their need resolved? And is that equitably distributed amongst different populations? And how do we make sure that people are getting the service they need at the right time, at the right organization to have the right outcomes? And so I included just a quick animation, I guess, to steal Dr. Barker's words. I'm not big on animation in slides, but this is one just showing a really quick what it looks like in the platform to actually send a referral. And for those that want to see this in more depth, I'd be happy to meet and connect on that. And share some upcoming community information sessions where you can see demonstrations, et cetera. And then for users that are getting referrals, which is the community in most part, how are they using the technology to accept those referrals, to provide outcomes, to provide updates on the journey for people who are working with that same client or involved in that referral? So I think the overarching theme of what we want to do is make it so that these organizations that are part of the ToRCH model, so the state and local programs that are available, the managed care organizations that are responsible for someone's overall health, and as Dr. Barker pointed out, offer programs that we can get better utilization of that are available to their members. The social service providers at the community level and the health systems, the hospitals that are at the center of this work in their communities. How do we make sure that all of those entities are operating cohesively and all for the benefit of the client in real time? And that's where the technology comes in and allows these real time, warm handoffs so that everybody knows who takes the next step and ultimately how that journey ended for that client. And what that means is this technology should be in the hands of all of those organizations that are touching those clients' journeys. Because it doesn't mean that what we don't know or what doesn't happen is most individuals' social journeys don't start with their health plan. They don't start with their local hospital. They start at a community organization or a community fabric type organization, right? Where maybe they're talking to their pastor at their place of worship. My favorite example are the barber shops that we partner with, that where people are having vulnerable conversations, and that barber or that pastor can then say, "Hey, I'm part of this broader network, and I can help you. You shared you lost your job. I can help you get into a workforce development program. Or if you're concerned about being evicted, I have these partners out there that I can connect you with that will help you with eviction, right? Or it's making sure that you're not going to get evicted." And so it's a really exciting opportunity to meet people where they are, to be trauma informed so that people don't have to reshare their story over and over again. And again, as you can see, as that journey advances through the shared infrastructure, through that shared technology of Unite Us, you can see I've sent the referral. Did it get accepted? Great. I don't have to, as the referral sender, I don't have to activate yet. There was an outcome documented. Great. I can see that. In some cases, in the ToRCH model, services will be reimbursed, and then we use the data collected to reinvest in the moments to make sure that we have the right capacity to serve, and ultimately driving towards that better health. And I think one thing that's really powerful is that the managed care partners will get alerted as their members seek care at any of the ToRCH and Unite Missouri partners, where appropriate, right, within the realm of security and privacy protocols. But that's a really important moment in time where that managed care organizations can then activate within their own internal teams to either offer assistance in other social programs or use that as a moment to say, hey, I'm glad we've had a chance to get connected. I see you working with our partner at the food pantry. You're behind on, with your primary care physician. Can we take that step to make sure you get connected to someone, right? Because they have this incentive to make sure that people have their healthiest lives in front of them. So just a quick call out. I listed the 6 communities that are going first with the ToRCH model, but I also wanted to call out some of our other like really amazing community coalition partners around Missouri that are doing some of this work as well. I can see some of these folks on the call, including Barb Gleason. I see Barb on the call. She came on video, part of the Born network. I saw Marietta Hagen from the Own It network. I think I saw some folks down from the Care Partner network. So really exciting things happening in Missouri around health related social needs and social determinants, social drivers of health. So, really quickly, I want to take a second to talk through another state that has done a similar, but not an exact model. I want to be clear. It is a similar model just to share like what's happening in other areas of the country and how these models have worked. I'm not going to spend a ton of time on the background here. What's really important to call out is that North Carolina was the first state to really use an 1115 waiver to set up programming to reimburse and incentivize community-based organizations to provide these services. And North Carolina, different than the ToRCH model, they went through their managed care or what they call their prepaid health plans. So they used a slightly different modeling and mechanisms to make it happen. But they were focused on these 5 domains: food, housing, transportation, toxic stress, and IPV services. And so they started, rolling this out across the state. And what did they achieve? So good. They just celebrated their 2-year anniversary down in North Carolina a few months ago. And part of that 2-year milestone was the release of a third-party academic validated and accredited research evaluation. And so we were able to share some really exciting data points that I think indicate not just what these type of models can do, but what the future of this work could look like. And so things like in the first 2 years, and really it was almost closer to 18 months as they built this out, they were able to serve over 13,000 unique individuals, providing over 200,000 services, and did that through multiple hundreds of community-based organization and social service agencies. And if you're a community-based organization and you're having to manage 200,000 service delivery moments, you need a technology to be able to streamline that workflow. And so within the HOP or Healthy Opportunities pilot, they were also able to show that over time, not just that a reduction in the enrollees, the individual clients who were served by the Healthy Opportunities pilot, they were able to reduce their social needs across housing, food, and the transportation domains. But over time, as people stayed in the Healthy Opportunities pilot, their improvement continued to increase, right? Not just on the social needs, but the next bullet point is on the healthcare metrics that they were looking at in North Carolina as a measure of success. Did they reduce the unnecessary ED utilization? Were they able to improve inpatient hospitalizations? Did they have healthier birth weights? And the answer to all of those was a resounding yes. So we've achieved a more efficient way to get people connected to services and to understand how those services impact health. We were able to show excuse me, North Carolina was able to show better health outcomes for the individuals being served, and then they were also able to show a total overall cost savings from the Medicaid lens, including the cost of the services. They were able to show an $85 PMPM per member per month savings, including the cost of the Healthy Opportunities services when it came to unneeded or unnecessary healthcare utilization. I'm not going to read this, but I think Rachel's going to distribute these slides. And I think it's always important to share that it's great to talk about this work at the high level and it's great to drill down, but nothing matters more from my lens than the real world impact it has on individuals. And so this is like a really cool one that talks about how a single mom was helped by the Healthy Opportunities pilot. And I just wanted to call out really quickly too. I mentioned some of these stats earlier, but as of April of this year, North Carolina has tracked an $80 million total spend at the health related social needs side of the house. So those are the reimbursement totals, which means $80 million that were allocated to community based organizations and providers of social services to do more upstream work, sustainable funding for those community based organizations. They had close to just under 22,000 unique individuals enrolled in the Healthy Opportunities pilot, showing for those 22,000 an $85 PMPM savings, and with a real world estimated reduction of 6 less ED visits per member per 1,000 member months. And so I'm happy to wrap up there. I'll leave it with a quote from one of the participants, meaning one of the organizations using Unite Us in North Carolina around the success of the model. Happy to share the evaluation summary and report of the North Carolina Healthy Opportunities pilot. And I'm really excited to see the results start to come out from the Missouri ToRCH model, and seeing how we have impacted and you all have impacted the health and well-being of your communities. So I think I got everything in with just a minute to spare.